as host. I'm Jason Berman. I'm the CEO and Scientific Director of the CHEO Research Institute. I'm the VP Research at CHEO and a member of the Department of Pediatrics. Before I introduce this morning's speaker, Dr. Patricia Longmuir, we'll begin with our land acknowledgement. We use the land acknowledgement to recognize those who came before us, and we've included this at all significant meetings that occur at CHEO and in the Department of Pediatrics. And this is particularly poignant this week with tomorrow being the first National Day of Truth and Reconciliation. Ottawa is built on unceded Algonquin Anishinaabe territory. The people of the Algonquin Anishinaabe Nation have lived on this territory for millennia, and we honor them in this land. Their culture and presence have nurtured and continue to nurture this land. CHEO also honors all First Nations, Inuit, and Métis people and their valuable past, present, and future contributions to this land. So this morning, it gives me great pleasure to introduce our grand round speaker, Dr. Patricia Longmuir. Dr. Longmuir is a senior scientist at the CHEO-RI, a member of the Healthy Active Living and Obesity Research Group, and a member of the Ready, Set, Go program in our new programmatic structure. She's a registered kinesiologist, and her research interests are in the promotion of physical activity to children with medical conditions and disabilities, and the use of physical activity to prevent and/or treat morbidity. Her research assesses the capacity of children with medical conditions and disabilities to achieve a healthy, active lifestyle and examines the impact of interventions to increase physical activity. Dr. Longmuir works collaboratively with clinicians at CHEO and other pediatric hospitals to promote physical activity in research and clinical care. And so I really do want to highlight what's unique about Pat's work is it's really about health promotion and quality of life. And these are things that I think we tend to focus much more on disease treatment in much of our work, and so her work is really unique from that perspective. Pat has a couple of co-presenters with her this morning, and I'll have her introduce them and then begin her grand round. So thanks very much, Pat.
Thanks very much, Jason. Thank you everybody for coming this morning for our presentation on caring for CHEO patients through physical activity. As Jason mentioned, oops, my slide's not there. As Jason mentioned, I do have two co-presenters, so I'm going to talk first about some of the research that we're doing to enhance the physical activity of our patients. And then Hannah Cummings will present the research that she's been doing evaluating our physical activity counseling service as part of clinical care. Hannah is a third-year medical student at the University of Ottawa, so she's just starting her clinical time in third year, and she has been working with our group this past summer on the case series evaluation of patients who've previously received physical activity counseling. And then we will hear from Sharon Liff, who is a mom to a patient. Her son was a CHEO patient. He's now 19. But when he was a CHEO patient, he received the physical activity counseling in clinical care, and Sharon will share a family perspective on the physical activity support that we provided to her. So we all know that physical activity is very important for health. Typically, we hear that it decreases atherosclerosis and risk of obesity and helps with anxiety and depression. But it's also important to remember that we deal with children, and children, the right to engage in play and recreational activities is actually part of the United Nations Convention on the Rights of the Child. So children do have the right to play and be physically active, and states have to encourage the provision of appropriate and equal opportunities for play. Now, Jeffrey Doe, who is currently a resident in pediatrics at CHEO, but was a medical student doing research with me a couple of years ago, he examined the physical activity capacity of children with medical conditions and disabilities who were tested at CHEO, as well as the Hospital for Sick Children and Bloorview Children's Hospital Rehab Center. And he compared those data to data from 390 matched controls who did not report a medical condition or disability. And what we found was 10% of the patients met the physical competence guidelines. So they had the motor skill and fitness in order to be able to participate successfully in physically active peer play. And that was compared to 33% of the matched controls. And 33% of the patients met the daily behavior guidelines. So they were achieving the recommended level of physical activity daily, compared to 52% of the matched controls. And as you can see from the figure here that I've excerpted from Jeff's article, the physical competence measure, which again is motor skill and fitness measures, regardless of the clinic that the children were seen in, their scores were significantly below those of matched controls. So this was different from what we expected. We expected that children from some clinics would be better able to have physical competence comparable to their peers, and there would be deficits in other clinics. And we really found no difference between all of the clinics. Now, my postdoctoral fellow, a previous postdoctoral fellow, Shika Saxena, did an analysis of interviews and focus groups that we conducted with, in this case, it was children with cardiac diagnoses, parents of those children, and healthcare professionals and recreation professionals, and about how to support healthy active lifestyles for these children with cardiac diagnoses. And there was 4 themes identified, but the key point for this presentation is that parents felt very strongly that they needed help from healthcare professionals and from recreation professionals in order to achieve a healthy active lifestyle for their children, that they can provide support, ensure the family was eating a healthy diet, they can facilitate the child's physical activity, but they really felt that they needed the support from healthcare professionals because of their expertise in healthy active living importance and the impact of that on their child's diagnosis, and from recreation professionals to provide and support options outside of the school. So families really want extra healthy active lifestyle support, or feel that they need extra support from us. That led Shika to the second phase of this research, where we had a solutions meeting, so collaboratively with patients and parents and health and recreation professionals. We had a 1-day meeting in Toronto, and they just took the results that we had from the interviews and focus groups and decided what additional resources would be helpful and they wanted to have. And then we went ahead, and our team went ahead and created those resources. So there were these 3 handouts. The first one on being active generally, the second one on understanding the exercise test results, and the third one on understanding how to be active if you can't be involved in body contact activities. And in addition to that, we created 2 web pages that were on the website of the Canadian Congenital Heart Alliance, which they are on that site. 3 in-clinic posters to encourage parents to ask questions about physical activity, an in-clinic questionnaire that assessed quality of life issues that the parents completed in the waiting room, so that the nurses and doctors would have a heads up on issues that they may want to discuss. A clinic tracking question tracking form. So parents had said they think of questions about physical activity as they happen in the community, but they wanted somewhere that they could actually make note of those questions so that they remembered what they were when they came to their next appointment. And then we created a 1-day fun activity family event. So those tools or the resources that we created in that previous project, we're now testing in a multi-site RCT at CHEO with Stollery in Edmonton and London Children's Hospital. We're enrolling 150 children from 5 to 17 years with moderate or severe congenital heart defects. The recruitment for this study is almost finished. We're at about 135 children enrolled and complete. And these children, it's a randomized pragmatic trial of an in-clinic intervention by a clinic nurse or physician. During their clinic visit, if they're randomized to the intervention, they receive 5 key messages during a counseling session with their healthcare provider. And as well, there's clinic posters, and they get access to our CHEO Active website and kinesiology support. And then we measure their step counts with a pedometer 1 week each month for 6 months, and measure their quality of life and activities adequacy and predilection at the start and the end of their involvement in the study. And we're also measuring using EPIC staff clinic time and resources required for this intervention. So we hope to have the results from this project available by mid next year, next summer. Now, intervening to enhance physical activity is very difficult. Sedentary or inactive lifestyles are very difficult to change once they're established. And so prevention becomes very important. If we can, a lot of my research focuses on younger children, because if we can prevent them from establishing those sedentary lifestyles, it's much easier than trying to change them later on. And various theories regarding stages of change are available. We focus our research usually on the trans-theoretical model, which says that people move through these stages of change, from thinking they don't need to change to thinking maybe they're not sure whether they need to make a change, to deciding to make a change and preparing to take action, and then taking action and the maintenance stage. And the theories say that if you link the type of intervention is different for each stage of change, depending on where the child is at. So we're currently involved in several studies based on intervening to try and change physical activity. This is a study that Dr. Hannah Alazem is the principal investigator, along with myself. That's funded by PSI, and we are looking at children who are in that preparation stage for readiness for change. So they've made the decision that they want to change their physical activity. They are motivated to change their physical activity, but they're not confident that they know how to do that given their medical condition or disability. And so we enroll children and youth cared for at CHEO for a medical condition or disability. The study is primarily recruiting in cardiology, chronic pain, and rehabilitation, but the study is open to children and youth across CHEO. And so we're hoping to be enrolling in some other clinics in the near future. We're about halfway through, or a little over halfway through, our recruitment for this study. It also is a randomized control trial. So they do a baseline assessment, which is entirely virtual. We do questionnaires to assess their motivation and confidence for physical activity, and we send them an accelerometer that they wear for a week so we can measure their physical activity. And then they get randomized to either receive the intervention immediately or to receive the intervention after the 6-month assessment. And they complete the 2 other assessments at 3 months and 6 months. And the intervention is 2 hours per week for 12 weeks. It was designed to be an in-person intervention, and we've done 1 series of 12 weeks intervention in person a year ago. We're doing our 2nd in-person intervention starting now in September to this fall. And those take place at the RA Center on Sunday afternoons. And then because of COVID, we had to rejig things, and we've also offered the intervention through 2 1-hour per week Zoom sessions. And we did Zoom interventions earlier this year in the winter and spring and summer. And we will be doing another virtual intervention starting in November. And we're finding that some families do not want to do a Zoom intervention. They only want to have an in-person intervention. Other families only want to be in a Zoom intervention. So now we're balancing both. And we're hoping to show that by having the patients in the intervention sessions actually learn different activities and games and skills that they can play that are tailored to their medical condition or disability and any restrictions that they may have because of their medical condition, that they will feel more confident and able to participate in physical activity by the end of the intervention. The second study that we're involved in right now is focused again on children with cardiac diagnoses, specifically children who are receiving elective treatment of a congenital heart defect, either through surgery or through catheterization. And this study is one of our studies that is focused on prevention, trying to prevent sedentary lifestyles. We had previously did an observational study of these children as they grew from toddlers into school age, and we're continuing to observe that cohort, measuring their motor development and their physical activity. And we found that the children who are inactive and or have motor skill delays at 18 months of age continue to have inactive lifestyles and motor skill delays at 5 or 6 years of age. And so we are now trying to intervene as early as possible in conjunction with their treatment of their congenital heart defect. So we're enrolling mostly babies who've had surgery, but the children can be 2 or 3 years of age if they have a catheterization repair. And so they get recruited prior to their treatment. And then we start as soon as they're out of the ICU with the intervention. So that includes an in-hospital component to a play-based intervention that our staff do in hospital with the patients, and they teach the parents how to do that. They do that at home, and then the children have individualized activity plans for 6 months that are all play-based that the parents can do at home, and we're supporting them with weekly check-in phone calls. And the goal is to ensure that the children have the age-appropriate motor skills and age-recommended physical activity by the end of the 6-month intervention. And the last study that I wanted to overview today, just to give you an idea of how we're using physical activity across a broad range of CHEO patients. This is what we refer to as the HELP project, Healthy Lifestyles Project for youth waiting for mental health services. And these are children and youth 10 to 17 years of age who are referred to CHEO for specialist mental health support. And we are recruiting them through their referring clinicians. So prior to them actually receiving services from CHEO while they're on the wait list. Again, all of the assessments are done remotely. We're measuring emotional well-being as our primary outcome and quality of life, sleep, physical activity, and screen time through standardized questionnaires in REDCap. And the intervention is also based on a website access that they get access to a component of the CHEO Active website that's designed for this project, and that is designed to help them learn about the link between physical activities, sleep and screen time, and mental health. And also it provides goals setting activities and plans that they can, step-by-step plans that they can follow to try and make healthy lifestyle behavior changes while they're waiting for CHEO specialist support. So this is a new project that we're just launching the recruitment now of a pilot study to see how well this goes and whether youth are able to engage with these resources while they're waiting for specialist support, either in conjunction with their referring clinician or independently on their own. And we have funding from Frame to support this project. So the other aspect, as I've briefly mentioned before, that we offer through clinical care is our physical activity counseling service, which I think most people are familiar with. So we do provide physical activity or kinetic coping groups for inpatients on 6E and 6N, and have previously done outpatient groups as well for children with Charcot-Marie-Tooth syndrome. We also have individual physical activity counseling available to families, both who are inpatients and outpatients. The inpatient groups are 2 days a week during the school year and daily in the summer. The outpatient support is primarily May to August, although I have a growing wait list of people asking for it outside of those times, and we try to accommodate if we can. The individual counseling sessions are offered by University of Ottawa graduate students who are doing a master's degree in physical activity counseling and intervention. And the group programs are offered by those same graduate students in the summer, and then undergraduate fourth year kinesiology students during the balance of the academic year. That brings me to the end of our presentation, but it's always important to acknowledge that the children, youth, and families who engage in our research and clinical services are extremely important. We obviously wouldn't be able to do what we do without their support. And I also want to acknowledge the collaboration of my many clinical colleagues who allow us to recruit through their services and who refer their patients to our clinical care services. Of course, as any scientist will tell you, the people who really make this happen are our staff, fellows, and students. And these are just a few of the members of my team, past and present, who've contributed to the information presented today. So we're deciding to do grand rounds a little bit differently this morning, in that we are going to have opportunity for questions after each presenter. So before I introduce Hannah and go on further, I'm happy to take questions if there are any.
Thanks very much, Pat. Questions for Pat, please put them in the chat or raise your virtual hand.
It's Alec Mackenzie Jason, who is not skilled at either.
Or just call out if you're Alex.
Great talk, Pat. And it's wonderful. You've been sort of pushing this rock up the hill now before it was trendy to do for the last decade or so. And so it's just very impressive to see how well you've done. But enough gushing. What about the long term? The concern is, and it reminds me a bit of Stasha talking about obesity interventions, et cetera. The concern is you come in, you guys do something awesome, they lock in, but then we know these people often, and I hate as a geneticist to say, there's a predilection to a certain level of activity. So what happens 2 years out or longer? And it's tougher and more expensive to do that. But are the impacts you seeing having sort of, do they persist as much as one would like to see? Sorry, a bit of a tough question, but.
That's okay. And feel free to continue to gush. It's wonderful. That's a great question. And obviously getting funding to follow people for years is obviously a challenge. So we do build short-term follow-up into all of our studies of 6 months or a year or something like that. I've only once been able to do really long-term follow-up, which was 5 years out. And that was my master's project, actually. And it was basically the same project that I just talked about that we're doing with the cardiac patients at the time of cardiac surgery. But it was done, obviously, and my master's was a while ago. So the kids were getting their surgeries when they were older. So these were elementary school and high school age kids who were getting their cardiac repairs.
Right.
And they came into the study at about the 5th to the 10th percentile of normative data in terms of their physical fitness. That's at the time we were only measuring physical fitness. And we intervened for 3 months again, starting as soon as they were out of the ICU, and followed them up for 6 months, and the results were great. The kids in the intervention improved to the 50th percentile. The kids who were not in or were in the control group stayed at the 5th to 10th percentile. So exactly the results you would hope for. When we went back, I had the opportunity to go back 5 years later. The results hadn't changed. Wow. So the kids who received the intervention were still scoring around the 50th percentile, and the kids who didn't receive the intervention were still scoring around the 5th to the 10th percentile.
Wow, I did not see that coming. That is amazing. You flicked the switch.
It's actually, I tell everybody, it's the best study that I ever did. And it was really the motivation for the study that we're currently doing with the babies, because at the time we were just measuring fitness. We hadn't thought about the psychosocial side of things at all. The results shocked us completely. And the most interesting thing was compliance with the intervention was at least one doing the activities at least 1 day a week. So the exercises they were supposed to do, if they did them 1 day a week, we considered them compliant, which, if you know anything about exercise physiology, won't get you anywhere. Yeah. But in hindsight, our theory was that what we were doing, because these kids had just had their cardiac surgery, there's a huge amount of uncertainty in the parents in terms of what now. They know they're supposed to be better, but they don't know how quickly, they don't know to what extent, they don't know what to expect. And so by intervening at that stage, very early stage, and saying, not only can you do this, but you need to do this, it actually enabled them to adopt an active lifestyle comparable to their peers. And so, and that was maintained over the longer term. So I think that's probably the key for a lot of, if we can get in there at the time of diagnosis, when there's a lot of uncertainty and a lot of, when the parents really don't have a lot of questions, if we can get in there at that point, I think that's probably the key, but I don't yet have the data.
Okay, thanks very much.
Pat, I have a comment and a question building on what Alex has said. He's mentioned that you've been doing this work for a long time, and I think there has been increased uptake from patients and families, but also from the academic community. And as a testament to that is your first ranked grant in this most recent CIHR competition that we're all very proud of. My question for you is, your work is very collaborative, interdisciplinary. It's a great example of that. And our hope is that you will be able to move some of this work into the Wondorfer Care Building in an integrated way. And I just wonder if you could speak to, how do you see that new infrastructure, that Wondorfer Care, how that may enhance some of this work?
Well, thanks for the question, Jason. And we are excited to be included in the Wondorfer Care building. I think the most immediate impact will be that we will actually have space where kids can run around and throw a ball and not hit a computer screen or something. So that will have a very dramatic impact on our ability to counsel families, not only as part of research, but as part of clinical care. Right now, we can do a certain amount of assessing of movement capabilities, but some of the play skills like throwing and catching a ball, et cetera, that are really critical particularly for younger children to be active. It's almost impossible to do at CHEO. I think the other advantage of being in Wondorfer Care is that we will have a place as part of the rehabilitation kinesiology services. So we hopefully will be continuing to provide the physical activity services as part of clinical care and potentially be more visible to parents and families. We find now a lot of families, it's sort of like, oh, I wish I had known that this was available before, but they hadn't realized that it was available. And I think that higher profile will help, as well as obviously my staff and my students right now are as you said, very integrated on the clinical side, but we are generally hanging out in clinic waiting rooms and hallways and lurking in hallways for to talk to families and stuff. So actually having a clinical space to conduct our research and have conversations about our research as well as our clinical care will be a tremendous benefit.
Great. Thanks, Pat. Are there other questions for Pat, or if I'm just scrolling through?
I think given the time, Jason, we should probably get going with Hannah's portion of the presentation.
Perfect.
And we will have more questions, time for questions afterwards. So
great. Welcome, Hannah.
Now I just need to, okay.
Awesome. Can you hear me okay?
Yep.
Perfect. All right. So my name is Hannah. I'm a current third-year medical student here at the University of Ottawa. And I worked this summer on a little case series that's still in progress called Impact of Physical Activity Counseling on Children with Medical Conditions and Disabilities and Their Families. Next slide. So as you are all well aware, physical inactivity is on the rise, and we urgently need intervention in order to address the various health risks that are presented by sedentary behavior. This is especially important here at CHEO because children and youth with chronic medical conditions are especially vulnerable to the health impacts of sedentary behavior, and they face many different unique barriers to physical activity. So one thing that we offer here at CHEO is physical activity counseling, as Dr. Longmuir described earlier. And this can help address some of those barriers that are stopping children and youth with these chronic medical conditions from being active. Next slide, please. So in case you're not so familiar with our program, physical activity counseling has many different aspects to it. So it can be anything from increasing motivation, developing personal activity plans for the children and youth, helping to build their confidence in physical activity. It can also be relaxation or stress management, sort of coping with those using various skills. It also includes positive mental attitudes and positive self-talk, as well as enhancing their goal setting. So it uses these many different approaches in order to help children and youth become more active here at CHEO. Next slide. We wanted to study this physical activity program here at CHEO because it is very unique, but we don't actually know a ton about the overall perceived benefits and impact of our program. So this study, the objective was to identify the successes, the challenges, and the overall impact of our physical activity program here at CHEO by interviewing the very patients we are serving, so the patients and their families. So we took previous participants of our physical activity counseling program here at CHEO. Eligible participants were currently being followed by CHEO. They were at least 8 years of age when physical activity counseling was completed, and they were counseled between January 2015 and December 2020. We also interviewed the parents and legal guardians of eligible participants who were involved in or supported the counseling for their child. Next slide. Okay, so as I alluded to earlier, primarily we were interviewing these patients using a one-on-one semi-structured interview over Zoom. So we wanted to really get a sense of what they remember, because for many of them, it had been up to 5 years since their counseling, how it changed their impact, their activity back then when they did the counseling, and even today, what was helpful, what we could change about the program and make it used to make it better, whether they would do it again or whether they would recommend it to others. So after this interview was completed, it was transcribed verbatim for analysis on in vivo software, sort of coding the various themes that we found in the interview by 2 independent coders, myself and another research student. And then afterwards, we consolidated these codes and are going to be grouping them into themes using a coding framework. So we won't be getting rid of any themes, more so just using this framework to consolidate them and identify key areas of improvement. Next slide. In terms of preliminary results, as I mentioned, this is still ongoing, but here's just a brief overview of our recruitment. So there were a total of 28 children who were eligible, 24 of which have been contacted for recruitment. 8 children had agreed to participate, 2 whose parents were also eligible because they supported their counseling, and they also agreed to participate. We had 2 parents who agreed to participate without their child, either because their child wasn't interested or their child wasn't able to participate. And then there were 16 children who agreed to not participate for various reasons as shown in the diagram. Next slide. So here's just a little overview of the demographics for our participants. So you can see it is a wide range of ages from 13 all the way up to 19. We also have a good mix of male and female identifying patients and a good range of ages at the time of counseling, all the way from 8 up to 16. It also was a variety of number of sessions from as little as 2 all the way up to 10. And then, as I mentioned, a few parents in there who agreed to participate. Next slide. So as I mentioned, it's still ongoing, but here are some sort of initial concepts that we found from our participants. First of which, counseling helped to develop a new mindset for physical activity. For one participant, this was figuring out that physical activity doesn't have to be work. It can be games as well. It can be fun. It's not something that's supposed to be a burden for you. Another participant found that it changed how they viewed physical activity. They thought before that it was something they just had to do, but then they realized they could actually enjoy it. Next slide. They also, as I mentioned, learned how to enjoy physical activity. It helped make it more fun and actually enjoying it. And the counselor was able to propose different activities that they could do to learn how to love moving and doing sports, really working with the participants to find things that they enjoyed and could work for them. Next slide. So participants also really enjoyed the one-on-one aspect of counseling, just them and the counselor. One mother said that their child's favorite part was having that one-on-one time with an adult who wasn't their parent. Another said that it really impacted them having that attention and focus on the child for that hour they were together. Next slide. One thing we also found was counseling did not necessarily change participants' priorities. One young male said it did not change how much they liked playing video games, and they're still more prone to enjoy playing Minecraft over playing a game outside. Another said they just have other things, other priorities that go before physical activity, such as school and work. Next slide. Overall, one overwhelming theme that we found was that feeling of support by the counselor. So participants felt that it was really nice to feel heard and to be able to feel understood in their hearts. One mother also found that there are nice people that still care out there in the world for their child. Next slide. And one really meaningful quotation that I found in our interview was from one mother. When you have a complex child who can't walk, talk, or eat, having someone come in who is kind, listens, will work with what they can, come week after week, do the best they can, are pleasant and share experiences, it affects you emotionally on a higher level. It doesn't matter what they do, but someone cares enough to try. No one else can get it, and it affects you at a higher level. So this just goes to show that impact that we can have with our physical activity program here at CHEO, and that support that the counselor can provide to not only the patients, but their families as well. Next slide. Overall, we also found that most participants wish there were more sessions. One mother said, just as it was ending, my child was getting even more comfortable, and she felt as though there could have been a more sustainable output if there were more sessions and more, I guess, involvement and time spent with the counselor. Next slide. So overall, we've sort of grouped these into several emerging themes. First of all, counseling can enhance the perception of physical activity, not only increasing a participant's interest in physical activity, but also helping to foster a new mindset towards physical activity, creating something that is more holistic and positive view of physical activity and what it can be for them. Participants also felt very well supported in their counseling. They felt a sense of validation, of renewed hope, and they overall felt very heard by the experience with their counselor. Participants also wish that the program could be expanded with more sessions, more follow-up, more resources, and records to remind them later down the line so that they can actually remember their counseling experience better and use the skills that they learned more frequently. Next slide. So that's the preliminary research. More data will be available as we continue on, but I'd just like to thank my co-investigators and other team members who have supported the research. And I guess I can take any questions now. I know we're a little short for time, but just let me know if you have questions.
I think perhaps, Hannah, given the time, we'll have Sharon do her presentation, and then we'll have time for questions after that.
Perfect. Sounds good.
That is if Sharon is ready. Yes, she is ready.
Thanks, Hannah, and welcome, Sharon.
Good morning. My name is Sharon Liff, and I'm the mother of a wonderful son named Adam, who has a very rare disease called Pelizaeus-Merzbacher. He can't walk, talk, eat, or weight bear on his own. He relies on us for his every need. I'm also the sibling of a woman with cerebral palsy, shunted hydrocephalus, and Chiari malformation. Both have had seizures. Neither outcomes are linked genetically. I'm also certified as an aerobics instructor and a personal trainer, and have always felt and known that activity is key for everyone. You all do valuable work with the children at CHEO. They need all of you. Physical activity counseling enhances the proactive portion of health that would ideally keep all children functioning at an even higher level and be something that children can ideally do at home. Complex Care offered me the physical activity counseling at one of our appointments. I was very happy to agree to assistance from my son to help him directly and to teach me more about what is possible. I'm always looking for ways to engage my son and learn about what might help him. The experience itself. Lorraine was the counselor, and she was very professional and kind and wanted to work with Adam and myself. She took the time to ask questions and explain to me the progression of movement counseling in a general sense. It was good to have the knowledge and understand the methodology. She tailored activities and offered various activities to engage Adam. She had a bag of items to include scarves that could draw his attention, and he could see the flow of the movement as it moved, of course. As a mother of a child with severe medical issues, it was wonderful to have someone come to work with my son to engage him in a fun way. There was an element of playing everything she did. I saw that Adam was quite happy as well during their interactions. There's a lot of thinking outside the box based on the capability and needs of each individual. It may be harder to work with this group given how low functioning they are, but it is still very important. Adam was in his walker for a substantial amount of this for him to engage. This was not necessary, but this is what I thought would be best and more social and more fun. The one-on-one aspect made it easier to tailor the activities to his abilities and to where he was emotionally on that day. How it can help other families. It increased movement and teach families and children that physical activity can be fun and it's very important. Not everyone has the background or interest in being active, but everyone can learn and improve their lives. My background in my advocacy throughout his life has had the focus to enable him to have the most proactive life. Why? Because all of this is important. Proactive care and enjoyment of life and interaction. Social, even if third priority, is still very important. Society has become more sedentary, more glued to their phones and games. This not only affects physical health, but also affects communication among individuals. Everyone should have physical activity and making it fun, no matter how high or low functioning they are. I've seen the severely disabled left out and not included when there are physical activities and programs being designed. It is essential to keep everyone moving to the best of their ability while also keeping it fun. I fought for years to have Adam in his walker or standing frame during the day to keep his bones strong, bowels running, and to give him some social interaction as he would be at a higher level, be able to see eye to eye with his peers, teachers, and workers. The fight gets harder as they get older. We need everyone to have activity that is fun. The physical activity counseling is important for all children, and I would recommend it for adults as well. What a great way to bring in activity while having fun and learning more about how the body functions. Physical activity counseling supports all the great work that is done at CHEO and has the ability to make all children healthier and happier. Thank you.
Thank you, Sharon. Thank you very much, Sharon, for being here and sharing your and Adam's personal experiences. Really inspirational. So we have a few moments for questions for Sharon and Hannah and Pat.
As always, I can blather on, Jason. I'll talk until somebody wise steps in. Sharon, your point of view is really very impressive. Just going forward, are the Sharons of the world embedded enough in the research protocols, et cetera? Should there, a bit of a loaded question, but we talk about patient-centered research, et cetera. Are you guys getting a voice in actually protocol design, et cetera, and that kind of aspect from your perspective, Sharon?
Well, actually, I had volunteered to help where I could. Personally,
Yes.
I'm very passionate about activity. I'm also an engineer too, but I've been an aerobic instructor since 1994. I've always believed, even with my sister, anything they can do is wonderful. And I'll say that to everyone until people want to kick me out too. I could talk for hours on that, but it's very, very important. The way of passion that shows anything you, as you all know, anything you can gain is something. Like people always look at the high, oh, I can't get like run a mile in whatever, I forget what it's at, we're at now, 6 minutes, whatever the best is. If we can't get those goals, we have to be ready for those steps and to enjoy the steps along the way. Can I walk an extra minute today? Can I move my leg a little bit higher if I don't function well? You know what I mean? Like I get my son, I get up and down and I do 1, 2, 3, 4. I know, and he laughs at me. Sometimes I can get him moving, but anything you can do with anyone, high, low functioning, adult, child, is so important. It's been one of my main passions.
Okay.
I hope that helps. Let me know if it didn't.
We're picking up on that. But as far as sitting down and planning the protocol, Pat and those guys and Hannah, they're getting it right. And
yes.
Okay, very good. All
yes,
right.
very good. It's excellent.
I was digging for dirt. There's no dirt. Okay,
no,
wonderful.
No.
But Alex, I think Sharon's message is once we get off this Zoom call, we should all get off our bums and get a little physical activity between meetings.
Yeah, I'll lead you.
Any other questions or comments? Maybe I have a question for Hannah from an education perspective, you know, as a medical student where, you know, the world is sort of your oyster in terms of research opportunities. What attracted you to this particular research project and how do you intend to take these learnings forward into your clinical practice?
Yeah, I've been always very interested in sort of lifestyle changes that you can do to sort of help manage, but also prevent illness and disability. So I was really interested when I saw Dr. Longmuir's project listed for one of the options for our summer studentship. So I was really interested because I would get exposure to many of the different projects that she was doing over the summer, and even getting to be involved in the creation of this case series, from the Research Ethics Board submission all the way to conducting the analysis and hopefully getting the report ready for publication. So that's what I really found valuable. Is I think it's something that I can apply no matter what area of medicine that I go into. People really underestimate the impact that physical activity can have on your not only physical, but also mental health and well-being. So I'm very appreciative that I could talk to the patients and their families, because they're the ones we're supposed to be helping. And we often don't look at their experience as much as we should. So I think going forward, just incorporating this into my practice, hopefully in pediatrics, but wherever I end up, just making sure to remember to go back to that as well.
That's great to hear. And Pat really has been a trailblazer in this regard, working with populations that I think, generally many of us would think couldn't get involved with physical activity because they have, congenital heart disease or cancer or other illnesses. So. Great. Any other questions or comments? I'm just looking in the chat. Some very positive comments and thank yous in the chat to Pat and her team for this work. Well, if there's no further comments or questions, please join me in thanking Pat, Hannah, and Sharon for